Good afternoon, all. Welcome to the second session of Foundation Course in Palliative Nursing. Today's topic is Introduction to Pain and Management of Pain, Part 1. Today's faculty is Dr. Greeshma Nair. Let me introduce her. So, Dr. Greeshma Nair, she is currently working as a senior palliative care physician at Pallium, India. She has completed her medical graduation from FCPN Academy of Medical Sciences, Tirunelveli. She has completed her CCPPN from Pallium, India. She has done the further approach to geriatrics in palliative care course from Pallium, India. Currently working as senior palliative care physician for 5 years. Her area of interest is palliative care. So welcome, ma'am. Over to you.
Thank you, Malik, for the kind introduction. And good afternoon, everyone. So I know this is your second session on
Good afternoon, ma'am.
Yes, thank you. And so here we will be learning about pain. Introduction to pain and management part 1 will be covered in this session. Okay. Next. So what does pain mean to you? Can anyone unmute and answer? What was your feeling when you had pain?
Subjective feeling, man.
Pardon?
It's an unpleasant feeling.
Yes, unpleasant feeling, yes. Any other?
Unpleasant sensory and emotional experience, ma'am.
So why there is an emotional component? What was your experience?
Pain, maybe some
Aching, madam, burning.
Okay. Any other? How was your day when you had pain?
Very dull, uneasy feeling.
Okay. So, yes. Next. So, can anyone answer who is being shown in this picture? Next. So, here you can read, right? So, this is Robert Tykros. He's one of the pioneer in palliative care, and according to him, pain is what the patient says hurts. Okay. So, what is pain? So, as some of you have said, it's an unpleasant sensory and emotional experience. So, from that itself, it is very clear that that is not physical. There is an emotional component also there in the pain, right? So, which is associated with or resembling that associated with actual or potential tissue damage. What does that mean? So, for example, if you have any, some of you have seen patients with POVD, peripheral occlusive artery disease, or diabetic neuropathy or peripheral neuropathy. Is there any visible tissue damage there?
No, ma'am.
No. But the patient is having burning pain. Some of you were telling burning sensation, right? So, why they are having that sensation? Because of the nerve damage, right? So, it is not necessary to have this actual tissue damage like burns or tissue injury or like that big. Okay. So, even in that absence, the patient can experience the pain, right? So, we are telling that it is not actually the pain has an emotional component also there. So, even in the absence of any potential tissue damage, actual or potential tissue damage, the patient can experience pain. So, usually what when we are seeing a patient and patient is well dressed and patient is smiling and patient, when you are asking that how is your pain or how are you, the patient is telling you, "Oh, I have severe pain." So will you believe the patient?
Yes, ma'am.
Yes. Why? Actually, we should believe the patient. So according to Robert Tigros, pain is what the patient hurts, and we should believe what patient says. Okay, because it is a subjective experience, right? So next. And the concept of total pain was put forward by Dame Cicely Saunders. Next. This is the total pain concept. Pain is not just a physical experience, it has an emotional response, it is a social impact and spiritual meaning. And I hope all of you know Dr. M.R. Rajagopal. Is there anyone who doesn't know Dr. Rajagopal? Do you know? Do you know him? Say yes or no?
No.
Yeah,
No.
okay.
No, no, ma'am.
Okay, in the first slide, the picture was. Can we move to that picture? No, previous one. Yes, this is Dr. M.R. Rajgopal. He is seeing one patient. Actually, he is the founder of Pallium India. In 2003, he founded Pallium India, and he is well known as the father of palliative medicine of India. Okay, okay, we can move on to that. So, according to Dr. M.R. Rajgopal, pain causes more pain and all pains are real. Okay, so these are not just one sentence. There are many meanings behind that. And when you are seeing patients, you can relate it, okay, in future. So, what is total pain concept? I have already read out the things. So, can anyone explain what is the social impact a pain can have on the patient? Can you imagine?
Patient is suffering with the pain and the family will also affect, madam.
Yes, of course. Yes, next. So this is the total pain concept. What is that? Suppose a patient is having some diagnosis, whatever it may be. So I hope you know what are the diseases which comes under the palliative care. So here we are dealing with the palliative care and the pain. Today's class is also based on the palliative care. Okay. So suppose a patient is having chronic pain, for example, fibromyalgia or myofascial pain syndrome or POVD or any other or some cancer. Okay, these are chronic conditions, right? Is there any complete cure for these conditions? No. So once the patient is diagnosed with these diseases, they will be dealing with the symptoms of this disease throughout their life, right? So one of the symptoms is the pain, right? So when a patient is having pain, their physical activities, everything is being affected by the pain. So suppose imagine you have severe headache. Will you be able to listen to this class peacefully? Will you be able to concentrate? No.
No,
No,
ma'am.
Or will you be able to work or go to the work with severe pain as effective as a normal day?
No, ma'am.
No, ma'am.
No. And
No.
for one day, your life is affected like that. So how the person's life will be when it is being there for in their life for long term or in a chronic basis? Each day is affected, right? So they don't know when they will get a cure from this or how their day will be in the coming days or coming months or years. Right. So the physical and the sleep may be affected. They may not be able to take the food properly. They may not be able to chew the food, or the taste may be affected. Right. So when a patient is diagnosed with some conditions which is coming under the palliative care, not only the pain, there will be many other associated symptoms also, many other symptoms also, and this pain itself can cause other symptoms like sleeplessness or like that way. So all these are interconnected, but one thing you have to understand is physically they are affected, and the second thing, psychological, how they will be. Of course, the pain itself has an emotional component. Other than that, because of the treatment, suppose a patient is going for chemotherapy or radiotherapy, huh? Early morning they have to wake up, they have to prepare and go to the hospital, they have to wait for long hours to get an appointment to the doctor, right? And we are seeing many patients, right? And at the end, after taking all these treatments, the doctor is telling that the disease is at stage 4 and there is nothing more we can do. So how they will be? Suppose a patient has spent everything they have, the financial stability is also affected. So how they will be feeling? There is a chance for anger, having anger towards the doctor or the treating medical team, right? Or anger at the therapeutic failure, anger at delays in diagnosis. I used to see many cases like the patient used to go for treating. Uh, suppose if suppose there is a symptom like abdominal pain or anything, but in the initial stages, the doctors or the treating person may not be able to identify that. Even this in the imagings are like UCT or UST or anything, there is less chance for getting in the initial stages, right? So there is high chance for missing the diagnosis, or an abdominal pain like gastritis can be misinterpreted as GERD or any other small diagnosis like what gastritis or like that way. But 1 year after the patient is diagnosed with some serious illness, then how they will be? They will be they will be angry towards the medical team. Or
Medical.
this, yeah, and disfigurement. See a breast, see a oral cavity, see a tongue, or even any other. These are some of the diagnoses which cause disfigurement. Diabetic food, which cause the amputation, right? So that can happen. And after chemotherapy, I have seen one patient who came to the OPD, and she was showing her palm to me, and she was explaining, I was very beautiful doctor, but look at my palms now. That turned into the blackish discoloration, the nails in the skin color changes, and she was having hair loss, and the total appearance itself has changed. We know when a patient is diagnosed with CA and all, they become emaciated, and they may not be able to take proper feed. So their appearance, everything will be affected, right? So uh, psychologically, the patient is affected. Fear of pain or death. So one day when we are having some pain, we know once we take the paracetamol, the pain will go. But what about these patients? They cannot even what nobody can tell them what will happen the next day, right? whether they will have pain or pain relief or any other symptom or how their disease will be. So there will be some anxiety factor also, or fear of pain or fear of death when okay, and feeling of helplessness. And social, what are the social factors? Suppose a patient is having severe pain and they have to take the treatment, they may not be able to do their work. So they may not be able to provide for the family. Suppose a breadwinner of the family is affected, and there is high chance for him to feel like a loss of role in the family because he is not providing now. So whether the family will hear him, or loss of social position, loss of job, prestige, and income, worry about family and finances. If a breadwinner is affected, you can imagine, right? If there is no other financial stability for that family, that entire family will be affected by that one diagnosis. The children may not be able to go to home, no, sorry, school. And even if one other member of the family is working, we know even to take one injection, what we ask to the patient, is there any caregiver who accompanies you? Only if there is any proper caregiver, we can give an injection. So what about this CT, chemotherapy, radiotherapy, and all? One family member has to accompany this person, right? So both of their work life will be affected. So the entire family is affected with the diagnosis. So when you are seeing a patient next time, you should treat them with all these things in mind. Okay, they are sparing their time, energy, and everything, and they are coming to you with their symptoms, with their difficulties. So we are just seeing them for at least 5 or 10 minutes or 30 minutes, right? So when we are giving, or when we are seeing the patient, treat them with uh, what? Love or full respect. Ensure the dignity of the patient and the family. And okay, and feeling of abandonment, and try to understand the patient. Once the patient and the caregiver feels like they okay, this person or this doctor or the nurse is understanding me, or they are with me, that itself is a very what very good thing we can do to the patient. Okay, in all cases, we may not be able to cure the patient, but in everything, in every cases, we can, what we can do, we can give comfort care for the patient, right? Cure is not possible in all cases, in all diagnoses, but comfort care is always possible. So, what is the spiritual thing? The patients can have doubts like, why this has happened to me? I was not doing anything wrong to anyone. So why does God allow me to suffer like this? I was offering prayer to the God. I was going to church regularly. And even after all these things, this has happened to me. So why? What's the point of it? Is there any meaning or purpose in life? And I'm suffering like this. And can I be forgiven for past doing? Some person will connect this to the all past wrongdoings. Okay, so these are the spiritual questions, and all these we can find if we are taking the proper history. When we spend some time with the patient, they used to not in the first visit, but frequently when we are seeing the patient after building the rapport and all, they will come up with these questions. Doctor, I'm suffering like this. Why this is happening, or what? Okay, so you should understand that we cannot answer to all these questions, and there is no answer for all these questions. But what we can do, we can listen to the patient. We can understand this is a spiritual aspect of the pain. So we should not be judgmental. We should not compare their situation with other or next patient. We should not belittle their suffering also. We should acknowledge their suffering. We should understand. Okay, next. So these are the total pain concept: physical, psychological aspect, spiritual aspect, and social aspect. And we are moving on to the next session. And to for identifying or for learning more about pain, You should know all these definitions like noxious stimulus. You might already know this. A noxious stimulus is one that is potentially or actually damaging to body tissue. Okay, for example, fire, fire injury or burns, or a pin pricking, or needle prick, or any example that you can give for a noxious stimulus? Stimulus that is potential, that has the potential to cause actual tissue damage.
Knife cutting.
Yes, knife cutting. Yes, there is tissue damage, right? And nociceptor. What is a nociceptor? A receptor preferentially sensitive to the tissue trauma or to a stimulus that will damage tissue if prolonged. That means what? It's a receptor which perceives the noxious stimulus. Okay. And nociception, the process of conveying information about this tissue damage to the central nervous system. Okay, next. That process is called nociception. And dysesthesia is an unpleasant abnormal sensation. Paresthesia means an abnormal sensation. Allodynia and hyperalgesia is pain caused by a stimulus that does not normally provoke pain. Okay, for example, the wind. Wind doesn't cause pain, right? But if the wind is causing pain for the patient, or touch, normal touch, or what, a dress, usually we are putting clothes, and the clothes will not cause any pain generally, right? But if wearing clothes itself is causing pain for the patient, the contact of this cloth, or wind, or the fan in the room is causing pain, what does that mean? The patient is having some abnormal sensation, like the pain is caused by a stimulus that does not normally provoke pain. That condition is allodynia. Okay. And hyperalgesia means the increased response to a stimulus that is normally painful. For example, pinprick is usually painful, but that sensation is more than normal. Okay. Then what is that? That is hyperalgesia. Increased response to stimulus. Okay. That is normally painful. Is it clear for all of you, all these terms?
Yes, ma'am.
Okay, next. Next. And we are moving on to the pain pathway. So we will play the video. Okay. Video. Sound delay.
Pain. As undesirable as it might seem, pain is actually a very important defense mechanism. It warns the body about potential or actual injuries or diseases, so that protective actions can be taken. Basically, noxious signals send impulses to the spinal cord, which relays the information to the brain. The brain interprets the information as pain, localizes it, and sends back instructions for the body to react. Pain sensation is mediated by pain receptors, or nociceptors, which are present in the skin, superficial tissues, and virtually all organs, except for the brain. These receptors are essentially the nerve endings of so-called first-order neurons in the pain pathway. The axons of these neurons can be myelinated, A-type, or unmyelinated, C-type. Myelinated A fibers conduct at fast speeds and are responsible for the initial sharp pain perceived at the time of injury. Unmyelinated C fibers conduct at slower speeds and are responsible for a longer-lasting, dull, diffusing pain. First-order neurons travel by way of spinal nerves to the spinal cord, where they synapse with second-order neurons in the dorsal horn. These second-order neurons cross over to the other side of the cord before ascending to the brain. This is how information of pain on the left side of the body is transmitted to the right side of the brain, and vice versa. There are two major pathways that carry pain signals from the spinal cord to the brain. The spinothalamic tract. Second-order neurons travel up within the spinothalamic tract to the thalamus, where they synapse with third-order neurons. Third-order neurons then project to their designated locations in the somatosensory cortex. This pathway is involved in localization of pain. The spino-reticular tract. Second-order neurons ascend to the reticular formation of the brainstem before running up to the thalamus, hypothalamus, and the cortex. This tract is responsible for the emotional aspect of pain. Pain signals from the face follow a different route to the thalamus. First-order neurons travel mainly via the trigeminal nerve to the brainstem, where they synapse with second-order neurons, which ascend to the thalamus. Pain from the skin, muscles, and joints is called somatic pain, while pain from the internal organs is known as visceral pain. Visceral pain is often perceived at a different location in a phenomenon known as referred pain. For example, pain from a heart attack may be felt in the left shoulder, arm, or back, rather than in the chest, where the heart is located. This happens because of the convergence of pain pathways at the spinal cord level. In this example, spinal segments T1 to T5 receive pain signals from the heart.
So the pain pathway. So what is when there is a noxious stimulus, the nociceptor will receive this pain, and the first order neuron will transmit this impulse from the nociceptor to the dorsal horn of the spinal cord, and the second order neuron will carry this impulse from the dorsal horn of the spinal cord, and this neuron will cross over to the opposite side and will ascend upwards in the lateral spinothalamic tract and will reach the thalamus, and the third order neuron will carry the impulse from the thalamus to the cortex. Okay, and the pain is perceived in the cortex. This whole process is called nociception. Okay, this is the pain pathway. Okay, next. And this whole process is being divided into 4 steps: transduction, transmission, modulation, and perception. First, next. Transduction. What is transduction? Exposure to noxious stimulus, release of chemical substance, and depolarization and repolarization, and formation of impulse. Okay, that is transduction. Next. What is transmission? From the free nerve endings, the pain is carried to the spinal cord and to the thalamus and to the cortex. This is transmission. Okay, formation of impulse, then transmission of impulse. Next, modulation. Modulation means the pain can be modulated, okay, at certain levels, which is being done by the descending pain inhibiting system through the endogenous opioids like endorphins, enkephalins, and other the physical, psychosocial, spiritual factors also influence the pain. Okay, so the pain can be modulated. Next. So descending pain inhibiting system has periaqueductal gray matter which is present in the midbrain, and magnum raphe nucleus, which is located in the medulla and the pons. Next. So here also we can play the video. Oh, sorry, we cannot play the video. So I will just explain. Okay, this is a supraspinal inhibition of pain. So you can see descending pain inhibiting system has periaqueductal gray area, uh, which actually has encephalinergic neuron, and which, when activated, will release the opioid peptides. Okay, and this periaqueductal gray area also acts on the serotonergic neuron, and which is present serotonergic neuron, which is present in the raphe magnus nucleus. And this periaqueductal gray area also influence or sensitize the catecholaminergic neuron, which is present in the locus coeruleus. So through the encephalinergic neuron, serotonergic neuron, and catecholaminergic neuron, what does these neurons will do? Through the opioid peptides, which is being released by the activation of encephalinergic neuron, and through the activation of catecholaminergic neuron, there will be release of adrenaline and all. And all these chemicals will act on the dorsal horn of the spinal cord through the inhibitory interneuron. So, what does this inhibitory interneuron do? That will reduce the transmission of impulse from the presynaptic to postsynaptic region. Okay, so there is inhibition of this pain. Okay, the pain pathway will be affected. Transmission of pain stimulus is reduced at the dorsal horn of the spinal cord through the inhibitory interneuron. Okay, next. Next. So, nociception, there are 4 steps. You have seen what are the 4 steps of nociception. And is there anything I have to repeat, or is it clear for all of you?
Clear, ma'am. It's clear.
Okay. So we are moving on to the types of pain, nociceptic and neuropathic pain. Till now, we have cleared what is pain, what are the total concept of pain, for concepts, and the certain terms we have discussed, the pain pathway and the nociception, the 4 steps of the perception of pain, nociception. Okay, now we are moving on to the types of pain. Okay, there are 2 types of pain, nociceptic and neuropathic pain. Nociceptic means what? Nociceptic is again divided into somatic and visceral, and neuropathic pain is again divided into nerve compression, the nerve damage due to nerve injury or due to nerve compression. Okay, next. Okay, what is nociceptic pain? Pain sensation resulting from injury of tissues. So stimulation of, injury of tissues. Okay, that can be somatic or visceral. Soma means what? Soft tissue, right? Soma means tissue. So somatic component means the pain which is perceived in the bone, muscle, soft tissue. You should be clear about this. Okay, the types of pain. Then only we can treat the patient. There are 2 types of pain, nociceptic and neuropathic pain. Nociceptic means injury of tissues. We know our whole body is made up of tissues. So, soma means somatic component means the pain which is perceived in the bones, soft tissue and muscles. And viscera means what? Visceral pain means what? The pain which is in the internal visceral organs like bowel, cardiac, lungs, etc. Okay. Next. And neuropathic pain. Neuropathic pain means which is resulting from injury to the nerve or due to the nerve compression, which is related to the nerve, not to the tissues. Okay, is it clear? The other thing is the tissue, and the second type of pain is neuropathic pain, which is solely belong to the nerves. Okay, either due to the nerve damage or nerve compression or injury to the nerve or anything. Okay, so how we can differentiate this neuropathic and nociceptive pain, or yes, nociceptive pain, from the quality of pain the patient is telling. Okay, so usually neuropathic pain, the quality of pain is burning, pin pricking, stabbing, lancinating kind of pain, shooting type of pain. Okay, next. So coming to the visceral pain, the pain is poorly localized and it can present as intermittent pain, crampy pain, or colicky pain like that pain. Next. And somatic pain, oh, someone has asked me to explain in the chat, right? I don't know. Okay. Somatic pain, precisely localized pain. Pain described as intense, constant, sharp, knife-like aching, throbbing pain with it can be associated with local recording or rigidity. So, suppose a patient is telling you aching pain, you should relate it to the somatic component of the pain. Okay. And throbbing, intense, constant, sharp pain, knife-like pain. Okay, if it is a burning, lancinating, or shooting type of pain, pin pricking type of pain, or wound-like pain, or burning pain, then you should relate it to the neuropathic pain. The quality of pain you should differentiate. From the quality of the pain patient is telling, you should be able to differentiate the type of pain. Is it clear?
Yes, ma'am.
Oh, okay, you can read out all these things later. You should know that these certain things, like from the quality, we can differentiate the type of pain. Okay, next. And based on the what the time when the patient is having pain, it is being classified into baseline pain, breakthrough pain, incidental pain, and all. And based on what is baseline pain, the pain which is felt by the patient most of the time, it is predictable and can be continuous or intermittent. Okay, breakthrough pain means the pain which occurs on and off and is unpredictable. Okay, anytime the patient can have that pain. Next, incidental pain. Only when there is a particular incident, like for example, cough, or during certain movements, or during positioning, or some certain activities. Only during that incident, the patient will have pain. End of dose pain. What is that? Gradual onset of pain which occurs prior to the next scheduled dose of analgesics. So before the next dose, if the patient is experiencing the pain, that means what? That is end of dose pain. Okay, these are important. Why? Suppose if a patient is having continuous pain and the pain relief is not adequate, and from the history we can identify whether it is end of dose pain. If it is end of dose pain alone, we can increase the dose or increase the frequency of the medicine and the pain we can manage. If it is a continuous pain, sometimes we may have to what add an adjuvant, or we have to if the dose is optimum, then we may have to switch to another drug, or we may have to move on to the next step of analgesics. Okay, so you should know these four terms, like baseline pain, which is there throughout for the patient most of the time. That pain, the pain which is there most of the time for the patient, is baseline pain. Okay, and end of dose pain is which occur prior to the next scheduled dose. Breakthrough pain means the pain which is there on and off, that we cannot predict. And one thing you should keep in mind is that all these pain can be present in one person. Okay, there can be more than one type of pain in one patient. Sometimes a patient can have incidental pain, baseline pain, breakthrough pain, end of dose pain. Okay, it can happen. Okay, next. Central sensitization. When the pain is experienced over a prolonged period of time, the sleepy receptors, that is nociceptors, get sensitized. And the adjacent neurons are also get stimulated. The process is called recruitment, and the pain increases in severity and which become more widespread pain. So the central sensitization can happen in chronic pain conditions. Okay, so it is necessary to treat the pain in the initial stage itself. So if the pain is left untreated, then what can happen? Uh, it can cause recruitment. That means adjacent neurons also get stimulated, and that areas will also be felt as having pain and all. So the pain severity is also increased, and there will be more widespread pain. So we should treat the pain as immediately as possible. Okay, next. And history taking. I have already mentioned this. We should actively listen to the patient, don't interfere, and details of comorbidities like diabetes, everything we have diabetes, hypertension, age of the patient, any other allergic history, details of the drug history, everything we have to ask. Okay, any gastritis for the patient, peptic ulcer, or we are giving this analgesics and all right. So we should know all these things. From the history, we should know any previous kidney injury, acute kidney injury, or renal failure if it is there, or any peripheral neuropathy or anything. Okay, comorbidities we should ask. The age of the patient is important. Their hydration and all is very important. Their food intake, everything we should know. Next, the pain. Next. So here there are some more points. Next. Okay. So, suppose a patient is telling you he is having pain in the chest region. Okay. So, what are the things you have to ask the patient? Where is the location? When the pain has started, duration, the pain, palliative and provocating factors. What is that? Anything which is increasing the pain, any activities or any factors which is increasing the pain, or any thing, any palliative factors. Okay. Uh, and quality of the pain, I have already mentioned. Radiation of pain, whether the pain is radiating to some other parts, or severity of the pain. Severity, how to assess the severity, we will learn in the coming slides. Okay, and the temporal factors, whether the pain is more during the daytime or in the nighttime, or whether it is present throughout the 24 hours, if the pain is there or not. An impact on the ADL. Impact on the ADL. So how their activities of daily living is being affected with this pain. Meaning of pain. What does that pain mean to that patient? Okay, so all these factors we have to ask. So what are the things? Location, duration, palliative and provocative factors. These are very, very, very important. If the patient is having multiple pain, for each pain we have to get all these details. Suppose a patient is telling pain on the abdomen and the chest. So we have to ask all these characters of the pain. These are characters of pain for each pain. For each pain, we have to have a separate table. Okay. What is its importance? Once we do the follow-up, we can actually, if we are knowing the correct severity, where are all the pain sites, duration, the quality of pain, temporal factors, if a patient's daily living is affected, how much improvement that came during the follow-up, all these things we can assess. If we have a proper pain score or severity, if we know on the during the follow-ups, we can know whether the patient is getting adequate relief, how many hours they are getting relief, like that way. And meaning of pain. So we should not assume the pain is causing more problems for the patient, not like that. We should ask that what are the things that is being affected with the pain, and what does this pain mean to you. Suppose sometimes the patient, because of the pain, their family life is affected. For some patients, their children's education may be affected because of the pain, because of their physical pain. So we should ask them, okay, which part of the patient is being affected most. Okay, next. So this is the body chart. So in our OPDs, we have actually, when we were following the case sheet, we had this pain chart, and in digitally also you can save this. Here you can mark where the patient is. This location you can mark. Okay, location you can mark, and everything like score, or you can give different shapes or different colors to mark the different type of pain or a different pain. Okay, so next, pain scales. Unidimensional, multidimensional pain scales. There are unidimensional, multidimensional pain scales. Unidimensional pain scales are verbal and non-verbal. In verbal, numerical pain rating scale, visual analog scale, and categorical scale. And non-verbal pain scales, Von Becker's Faces scale. And in multi-dimensional Magdal pain questionnaire, brief pain inventory and all is there. In Pallium, we generally follow NPRS, VAS, and categorical, and Von Becker's Faces scale. Next. And this pain scale is also very important. All these characters are very important, because even if you miss one of the character of pain, that history is incomplete actually. Okay. Location, duration, palliative factors, provocating factors, severity, radiation, temporal factors, ADLS, how the pain affected their activities of daily living, and what does the pain mean to that patient. Once you ask all these characters, the history of pain will be complete. Okay. Okay. So numerical pain rating scale, that is, it's a scale, normal scale from 0 to 10. And we should explain to the patient like 0 means no pain, and 1, 2, 3, as the numbers goes up, the pain also increases, and the 10 is the worst imaginable pain for that patient. So after explaining the numerical pain rating scale, we should ask the patient, what is their score? How much score they are giving for their pain? Okay. Is it clear how to explain the numerical pain rating scale? 0 means no pain, 10 is the worst imaginable pain, and 1, 2, 3, as the numbers goes high, the pain increases. Okay, next. And here, this is Von Becker's Faces pain rating scale. Here you can see the pain measurement scale. 0, 1, 2 is mild pain. 3, 4, 5, 6 is and all moderate pain. 6, 7 is severe pain. 7, 8, 9 and all very severe pain. Worst imaginable pain is 10. Okay. And from the expression of the patient, or we can ask them, you can show this scale, pain measurement scale, to the patient. It is easily available in the Google the online shop also, it's available, so you can get it in your OPDs, and you can show this to the patient and ask them to show you which phase is mostly you can see from the patient's face itself, and we can ask them also. Okay, next. Categorical scale. No pain, mild, moderate, severe, and excruciating. For some patients, it is very difficult for you to explain all these things, and even after repeated time, if you are telling the patient and asking the pain score, you may not be able to identify the exact pain score. So in such cases, the patient is illiterate or the patient is in severe pain, and all. You can ask this also: no pain, mild, moderate, severe, and excruciating. Okay, I don't think there is much explanation needed for this. Okay, next. And we are moving on to the principle of pain management. Okay, so introduction of pain is completed now. So I hope you all know what is pain. Pain is a physical, not just physical, it has an emotional component also. And it is not necessary to have actual or potential tissue damage always, right? And the components of the pain, the types of pain: nociceptive, neuropathic pain. Nociceptive is again divided into what? Somatic and visceral pain. Neuropathic pain can be due to nerve damage or nerve compression. And the quality of pain: what are the quality of pain in neuropathic and nociceptive? You should know. And all the characters of the pain you should know. And the certain terms of the pain, like the pain pathway, the types of pain, like what is baseline pain, what is incidental pain, what is breakthrough pain, what is end of dose pain. All these things also you should know. Okay, and the pain pathway you should understand the pain pathway. Okay, and the modulation of the pain, the 4 steps of nociception: transduction, transmission, modulation, and perception. Okay, all these things, I hope it's clear for all of you. And now we are moving on to the principle of pain management. Treat the treatable. Previous slide. Treat the treatable, non-pharmacological management, and pharmacological management. For any symptom, we can follow this, right? What first thing we should treat the treatable causes which is causing the symptom. Here it is pain, so whatever things which is causing the pain, we should treat if it is treatable. Next. And non-pharmacological management. What are the non-pharmacological management we can do?
Cold
Then,
compression, hot
yes.
fermentation.
Yeah, hot and cold application, ultrasound therapy, relaxation techniques, distraction techniques, the TENS, all these things are available, right? And we can use it. If it is giving some relief for the patient, definitely we can try that. Next. And not only this, there are many other things like aromatherapy, acupuncture therapy, okay, music therapy. All these things are also being practiced in many parts of the world. So in India, it is just coming up only. So you can also read about all these things like aromatherapy in pain, acupuncture therapy for pain management, music therapy for pain management. Okay. Yeah. So yes. So coming to the pharmacological management, we follow the WHO analgesic ladder. What is WHO analgesic ladder? It's a stepwise approach to treat cancer pain depending on its severity. So severity is important. How to assess the severity? We have seen certain pain scales, right? Someone has mentioned laughter therapy, self-hypnosis. Can you explain, Sister Shanti, if you have some idea on that? How to do this laughter therapy or self-hypnosis? So we will come to you later after completing this principle of the pain management. Okay. So WHO analgesic ladder. So we should know the severity of pain. For that, we are using numerical pain rating scale. We know 0 to 10. We have to ask the pain score. Or categorical scale on von Berger's faces pain scale. Okay, so prior to this, WHO analgesic ladder, patients were dying in unnecessary pain, and there was stigma which is associated with prescribing and taking opioids. So there was no step ladder approach to treat the pain, and this WHO analgesic ladder legitimized the use of opioids. Next. So based on the recommendation of a group of international experts in 1986, this WHO analgesic ladder was put forward, and which was translated to 22 languages and which catalyzed uh, the treating cancer pain worldwide. And this is simple, effective, and well validated tool which is being used for treating cancer pain worldwide now. Next. So the principle of analgesic use. So what we have to follow: by the mouth, by the cloak, by the ladder, and individualized treatment. So here, by the mouth. By the mouth means if an oral route is available, we should follow that. Okay. Why? It's the most, sorry, it's the most easiest route, right? If an oral route is available for the patient, is there any need for giving the drug parenterally?
No.
No. There are many routes which are available, but if the patient is able to take the medicine orally, go with that. Okay. And we are seeing most of our patients in the home care, and we have to send them back to the home, right? We cannot treat all these patients in the IP units or in the hospital itself. And we know these are not just acute cases, these are chronic cases, and they have to be managed at the home itself. And the most feasible and easiest route is oral route, right? Most convenient route for the patient. So we should follow that. And by the clock, what does that mean by the clock? If a patient is having round the clock pain, we should give the analgesics throughout the day, right? So that there comes the importance of history taking. Baseline pain. If a patient is not having suppose a patient is not having baseline pain, only incidental pain the patient is having, is there any need for continuous analgesic for that patient? Only incidental pain patient is having, and that too happen only once in a time, once in a day. Is there any need for round the clock analgesic? No.
No.
No. Why? Only if the patient is doing that activity, and you have to ask the patient and the caregiver whether they are doing that activity or that incident is happening throughout the day. If that incident, like positioning, if the patient is having pain during the position, we have to change the position for a bedridden patient every 2 hours early. And every time the patient is having pain, then we may have to give some analgesic for the patient. If it is causing severe pain and if it is lasting for some time with the position and all. If it just goes without any medications with rest, if the patient is coming back to normal, then there is no need. Okay, I hope it is clear. Okay, so by the clock we have to give baseline pain. If the patient is having, if it is a continuous pain, then we have to regularize the pain medication according to that. By the ladder, what is by the ladder? According to severity, we have to give the medications, and by the ladder means WHO analgesic ladder. By the ladder, we will learn about the WHO analgesic ladder in the coming slides. And individualized treatment, what does that mean? So suppose a patient is elderly after 60 to 70 years with a kidney damage and all, and is this the same way we treat a young patient with severe pain? No, definitely no, right? We should be more cautious. Sometimes we may have to reduce the frequency in CKD and all, right? We should know all these things. Okay, individualized treatment based on the comorbidities of the patient, based on the risk factors patient is having, the treatment varies. So, okay, based on the risk factors, if there is any risk factor for the patient, we should be cautious. Okay, next. We cannot generalize the pain. Suppose some 5 patients having same diagnosis and having same site of pain, their pain severity may not be the same, and the effect of a drug for those 5 patients will not be the same. So individualized treatment for each patient, the scenario is different. So we have to treat individually. Okay, next. This is the WHO analgesic ladder. Here you can see 3 steps like, right, step 1, step 2, step 3. What is step 1? Step 1 is for mild pain. Okay, for mild pain, what we can give? Non-opioid plus or minus adjuvant. And what is step 2? That is mild to moderate pain. Okay, so for that we have to give an opioid. We have to add an opioid along with the step 1 drug. What? Opioid plus or minus non-opioid plus or minus adjuvant. And step 3, opioid, weak opioid we are using in the step 2. And in the step 3, we are giving strong opioids. Okay, strong opioids. What are the example of weak opioids?
Fentanyl.
Fentanyl is an example for opioid, yes, but that's a strong opioid. Any weak opioid?
Morphine.
Morphine is also a very strong opioid.
Tramadol.
Tramadol, yes. Tramadol is a weak opioid. Tapentadol is a weak opioid. We will learn about that today. So step 1 and step 2 we will be learning today. So non-opioid, okay, we will learn about that next. So step 1 drugs. Step 1 drugs these are used to treat mild pain, not moderate pain, sorry. To treat mild pain, these include paracetamol, NSAIDs, non-steroidal anti-inflammatory drug, and can be combined with an adjuvant drug. Okay, next. What are NSAIDs? What is the pharmacological action of this NSAIDs? We know our cell membrane has phospholipids, right? Cell membrane has phospholipids, membrane phospholipids, and by the action of enzyme, this arachidonic acid, from the arachidonic acid, by the action of the COX enzymes, prostaglandins will be released. What does this NSAIDs do? NSAIDs will inhibit the COX enzymes and will reduce the formation of this prostaglandins. So the prostaglandins, which is causing this inflammation and this pain response, is being inhibited by the NSAIDs by acting through the COX enzymes. Okay, next. So there are 2 isoforms of this COX enzymes, COX-1 and COX-2. COX-1 is present in all normal tissues, especially GI tract, platelets, kidneys, and all. So this COX-1 has a housekeeping action or constitutive action, which mediates physiological responses, protects the stomach and kidney, facilitates platelet aggregation, and all. Okay, so this COX-1 inhibition is not actually preferable. Why? That is a protective action. COX-1 has a protective action which is present in normal tissues and all. So once this protective action is inhibited, what can cause? Gastric irritation, it can cause platelet aggregation. If it is affected, what can cause? It can cause bleeding. In the kidneys, it can cause kidney injury, right? That is why this NSAIDs is causing this gastritis and all, because of the inhibition of COX-1 enzyme. Actually, this COX-1 enzyme is having a protective action on all these sites. What does NSAIDs do? NSAIDs will act on the COX enzyme. Okay, that will inhibit the COX enzyme. For why? It is inhibiting COX enzyme and it will reduce the production of prostaglandins. Thereby, pain will reduce. But because of this inhibition of this protective action of this COX enzyme, there will be some side effects like gastritis, bleeding, ulceration, kidney damage, or like that thing. Okay, next. And COX-2. COX-2 is actually inducible and occurs only when there is inflammation and which is present in lungs, brain, kidneys, testes, and which mediates prostaglandin synthesis, vasodilator, inhibitor of platelet aggregation and all. Okay, next. And the second thing you should know is there are many types of NSAIDs. There are one of the type is non-selective COX inhibition. Non-selective means it will block both COX-1 and COX-2. So examples are brufen, mefenamic acid, ketorolac, piroxicam, etc. Next. And the side effects of the non-selective NSAID is non-selective means it will inhibit the both COX-1 and COX-2, right? So I have already explained. If COX-1 is inhibited, all these side effects can cause. It can result. Sodium and water retention, acute and chronic renal failure, bleeding, ulceration, hypersensitivity, respiratory skin or generalized irritation for the skin and all. Next. Preferential COX-2 inhibitors. What is that? Blocks COX-2 relatively more than COX-1. Examples are diclofenac, meloxicam, nimesulide, etc. Next. Selective COX-2 inhibitors. Examples are celecoxib, proficoxib, valdecoxib, parecoxib, etoricoxib, lumaricoxib, diclofenac. Next. Next. Precautions with NSAIDs. So, administered with gastroprotective drugs like proton pump inhibitors. Is it necessary to give this PPIs every time? For every patient, will you give this PPIs? Not necessary, right? We can ask the patient to take this NSAID after food. So
Yes.
that itself will have some gastroprotection, right? So it is not necessary to give this PPIs for every patient, but if the patient is already having some risk factors or gastric irritation or some peptic ulcer, gastritis, then you can give PPIs. Okay. Otherwise, you can ask them to take this NSAIDs after food. Okay. Then cautious use in patients with acid peptic disease, advanced age, smokers, alcoholic, steroid, along with the steroid when we are giving, then CAD, hypertension, asthma, renal dysfunction, gout, etc. Okay. Ensure adequate water intake, avoid dehydration. So we should ensure hydration for the patient also. That will reduce the kidney damage. Next. Avoid if there is bleeding tendency or with anticoagulants, but it is not possible to avoid NSAIDs in the patients with anticoagulants in every cases. Okay. For example, if a patient is having stroke, post-stroke cases, a patient who is on ecospirin, clopidogrel, we used to give NSAIDs for patients with with ecospirin and clopidogrel and all. In such cases, what we have to do? We have to do the follow-up. We have to check whether there is any bleeding, any history of bleeding or any bleeding sites or any gastric irritation or like that. With the history, we have to do the follow-up. Okay. Suppose if a patient is having, after stroke, the patient is admitted in the bar or general IP unit or in the OPD, we are seeing the patient. The patient is having some contractures or during the physiotherapy, patient is having severe pain. The physiotherapy we cannot avoid, right? And we have to manage the pain also. In such cases, it is better to give the medication and watch for the risk or watch for the warning signs the patient is showing. Okay. Like bleeding, if any, or any gastric irritation or any pedal edema or anything like that. Okay. And COX-2 selective inhibitors is contraindicated in atherosclerosis, CAD, cerebrovascular diseases and all. So actually it is contraindicated. Why? Because there is this COX-2 selective inhibitors has some hypercoagulation, has a risk for hypercoagulation. So it can actually worsen the condition of atherosclerosis, CAD, cerebrovascular disease, more chance for causing all these things by causing hypercoagulation. But as I have already mentioned, we may not be able to strictly we may not be able to not prescribe the medications like this NSAIDs for these patients. In some cases, we may have to give this medication, but what we have to be very cautious is we have to do the follow-up. We have to explain the patient what are all the warning signs they have to look for. What are all the things that medicines can uh, have on the patient. Okay, side effects of the drugs, any areas the drug is having, we have to explain that to the patient and the caregiver. Okay, next. And the paracetamol. Paracetamol is also in the first line drug. So that has a predominant central action which inhibits the enzyme cyclooxygenase in the CNS, central nervous system. So no effect on peripheral cogs and hence less side effects. And that has an antipyretic and analgesic action, no anti-inflammatory action. Okay, next. The maximum dose of paracetamol is 2 to 3 grams per day. Next. So the dose of the paracetamol is 10 to 15 gram. Okay. Sorry, not 10 to 15 gram, 10 to 15 milligram per kilogram we are giving. Okay. So the maximum dose for a 60-year-old patient, or what? If you are giving 3 to 6 gram per day therapeutic dose of acetaminophen, it is okay, but we are not advising not more than 4 gram per day. Okay, better to keep it less than 4 gram, but up to 2 to 3 gram of paracetamol per day, even in case of chronic liver disease, it is safe for the patient. Is it clear? For a patient with CLD, we can give the paracetamol. We can safely practice paracetamol up to 2 to 3 gram per day. Okay. Not to give the paracetamol above 4 gram. Okay. Okay. And you may get some questions from the patient. I'm having these and all. Whether I should take this, I'm not taking this, like that way. So it is the most safest drug we can give to the patient who is in severe pain. Okay, we should tell them, we should explain them it is the safest dose we are giving in the very small dose only, and we can one thing we have to do is we should explain the areas of the drug gastritis, gastric irritation, any bleeding tendency, or if any urine output we have, we can check, and we can ensure adequate hydration. We can ask them to take the medicine after the feed and all, and we should ask all these risk factors in the follow-up time. Okay, next. And we are moving on to the step 2 drug, that is tramadol. And tramadol, this mechanism of action is it acts on opioid receptors. Okay, it acts on the opioid receptors and it inhibits the reuptake of serotonin and noradrenaline. Okay, by acting on the opioid receptors and by inhibiting the reuptake of serotonin and noradrenaline, tramadol will give the pain relief. Next. And the maximum dose of the tramadol is 400 milligram per day, and it is 1/10 potency. It has 1/10 potency of morphine. And one thing is, it lowers the seizure threshold. That you should keep in mind. If the patient is having some brain mets or any seizure history, or any raised intracranial tension like brain mets or brain any benign growth in the brain, better to avoid this tramadol because it will reduce the seizure threshold and there is more chance for the patients to have seizure. And dose limiting side effect is nausea, and duration of action is 4 to 9 hours. And here in Pallium, we prescribe this tramadol as 50 milligram BD or twice daily or thrice daily or even 6 hourly. Okay, we can give maximum up to 400 milligram per day. Okay, next. And the next drug is tapentadol, and that is also a weak opioid. Tramadol and tapentadol is a weak opioid. Okay, so tapentadol is also has the dual mode of action, which acts on the mu receptor as agonist and that has an inhibitory action by preventing the reuptake of serotonin and norepinephrine. Okay, and this is also available in the strength of 50 milligram. We can give 50 to 150 milligram 6 hourly up to 400 milligram per day. The maximum dose is same as that of tramadol, which is 400 milligram. It has same action as that of the tramadol, like preventing the reuptake of serotonin and norepinephrine. Okay, next. Codeine. Codeine is 1 by 10 potent as morphine, and the main metabolite of codeine is codeine 6-glucuronic. It is a prodrug of morphine, and onset of action is 30 to 60 minutes. Duration of action is 4 to 6 hours, and for pain relief, for cough suppressant, and antidiarrheal, we can use this codeine. Next. And coming to the adjuvant analgesics. What is an adjuvant? Is any drug that has a primary indication other than pain, but analgesic in some kind of action. That means, for example, we can take amitriptyline, that is a tricyclic antidepressant that has a primary indication is antidepressant, but that has a analgesic action. Okay, so in neuropathic pain, we have a neuropathic pain ladder. Like we can start with tricyclic antidepressant. The pain is not controlled with that. We can add along with that. We can add some anti-epileptics along with the tricyclic antidepressant, and we can modify the or optimize the dosage of this drug. And if the pain is not controlled, then we can move on to the next drug like NMDA antagonist like methadone, which is available, ketamine, and then comes the role of this ketamine like infusions, lignocaine infusion, ketamine infusion. All these things you will learn in difficult pain session. Okay, there you will learn about all these things. And here, next, adjuvant drugs, antidepressants, anticonvulsants. That has a role in the neuropathic pain. If the patient is having neuropathic pain, as an adjuvant, we can add what? This antidepressants. For example, if the patient is having aching pain, continuous aching pain, but at the same time they have a burning pain also. So the main baseline pain is this aching pain, which is radiating to the back, pain abdomen radiating to the back, to the lower limb and all. And they have a burning component also with that aching or throbbing pain. So you can get 2 or 3 quality of pain in one patient. Okay, so from the quality we can identify the type of pain. And here, if the patient is having this aching, throbbing, burning or catching pain, there is a nociceptive component as well as neuropathic component. So to treat the nociceptive component, we can start with WHO analgesic ladder like step 1, step 2 or step 3 based on the severity. If the patient is having score of 3, that means mild pain. So you can start with step 1 drug. You can start with paracetamol. You can regularize the paracetamol. And if the patient is having some neuropathy component, what you can do? You can add some antidepressants like amitriptyline in the lower dose, or anticonvulsant you can give like pregabalin you can give, or gabapentin is being prescribed for pain management if you are when you see the patient for the next day. Sorry. When you are seeing the patient next time, you just observe for what these medications are being given. Sometimes this pregabalin is not prescribed for the seizure. That might be prescribed for the pain management. Okay, so that is being used as an adjuvant there. And corticosteroid. Okay, what does the steroids do? That will reduce the peritumoral edema. That will reduce the compression on the nerves. So, if there is any peritumoral edema, this corticosteroids will helps to reduce this edema and thereby will reduce the compression on the nerves and will cause a relief for the pain. Okay, and bisphosphonates in order to improve the bone strength. Cannabinoids, ketamine, anesthetics, neuroepileptics, all these things can be used as an adjuvant. Anesthetic example, lignocaine. We used to give local application of this lignocaine for what? In piles or in hemorrhoids, in fissures, or in what? If there is any ulcerations, we used to give this local. We used to give this local analgesics, right? Silocaine. For example, if a patient is having some dysphagia after radiation because of this mucositis or this mucosal ulceration, suppose a patient is having oral CA and the patient was undergoing a radiation, and because of the radiation, patient might have mucositis, or if the mucositis also there is many stages, stage 1, 2, 3 and all. If it is severe, the patient will have severe pain. They may not be able to even swallow their saliva. In such case, what we can give? Here in Pallium, we give this lignocaine. Lignocaine spray also we can give, and silocaine gel we used to give. Okay. Not silocaine gel, sorry, Lox viscous, which is available as a liquid form. We will give along with that antacid. We will mix in equal amount, and we will ask the patient to hold that solution for 5 minutes and to hold it in the mouth and to spit it out. So that will give some numbness or numb-like feeling in the mouth, so that if the patient can have food, they can take the spicy food, they can swallow their saliva, and it is very helpful. But the effect will last for less than 2 hours only, because it is a local anesthetic, but they can take their feet. Okay, so these are the adjuvants, the role of adjuvants. And in Pallium, actually, we give this bupivacaine. Bupivacaine is a anesthetic agent. So we give this bupivacaine soft dressing for the patients with severe pain. For example, in cases like POAD, peripheral occlusive vascular disease, or in vasculitis. Sometimes the patient may have severe pain, vascular ulcers. The pain may be localized to the ulcer site alone. So in such cases, even after giving the analgesic, oral analgesic, the patient is having no relief, we can try this. We can give this local analgesic, bupivacaine soft dressing we can give. Sometimes the patient will get relief for 2 hours, complete relief, 0/10 pain relief. Okay, so that also we are using it here very effectively. And another thing is, all these things, after doing all these things, proper assessment, proper scoring of the pain, after starting the medications, you should follow up the patient. Okay. Here, if we are starting an opioid, we will do the follow-up within 48 to 72 hours. Strong opioids if we are starting. Morphine if we are starting, we will definitely follow up within 72 hours. Okay. So, we will ask whether the patient is having adequate pain relief, whether there is an increase in sedation or any other side effect like that way. We can or if there is no proper system in your hospital for doing the proper follow-up, you can actually give the number. You give your contact number of your hospital or your medical team uh, contact details you can give, and you can ask them to contact you. You can explain the side effects areas of these medications, and you can ask them to contact if there is any need. Okay, proper follow-up is needed. And if we know the score of the patient, for example, if the patient is coming to you for the first time and the score is 10, you are starting paracetamol regularly, and actually 10 means severe pain, we have to move on to the step 3. In the next session, you will get a session on step 3. And for, okay, here we have learned step 2. So the score is 6. Okay, 5, 6 and all is step 2, right? We have to move that is moderate pain. So we have to start with the step 2 drugs. So tramadol we are starting. And during the follow-up, we should ask the patient, what is the pain score now? Whether you are getting relief, how many hours you are getting relief. How many hours you are getting relief with this paracetamol or the tramadol. Okay, that all those things you have to ask. Okay, then only we will know how much relief the patient is getting with the medications. And if they are having some breakthrough pain, if they are having some end of dose pain, even after optimizing this medication, we have to move on to the next step. Or if there is any option for modifying the drug or modifying the frequency of drug, we can do that. Okay, so I hope it's clear. So we have completed step 1 and step 2 drugs. And you matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. Okay. Thank you. Is there any doubt? Then you can ask. So someone has mentioned laughter therapy, and mentioned in the comments like elevating the mood. Okay. So we know there are 4 aspects of pain, and we have to if the patient is having some psychological component, we have to send the patient to a psychologist for counseling. Okay. And physiotherapy need, it is there, we have to send them to a physiotherapist. All these aspects, and social officer should be there to cover their psychosocial concerns. If the social officer, psychologist, and all is not available in your center, you definitely can intervene all these things. You can get the details of you will get some sessions on psychosocial aspects and all in this program itself you will get. So here we have learned about pain, step 1 and step 2 drug, and the coming session you will get session on opioids, strong opioids. Okay. Yes, definitely we will send the learning materials to you. The PDF will be sent to you. Okay. And if you have any doubt, you can write to us, or all of you are in a WhatsApp group, right? So that group will be maintained even after this course. Also, in your practice, or when you are seeing some patient, we have some doubts, or you want some opinion, you can definitely reach out to us. So yes.
Yes, so our participant has asked about the PDF. The PDF will be shared on the IECO platform. So everyone needs to log in and select the topic which they want. They can access the PDF from there. So participants, if you have any doubts, you can ask now. or else we can wind up.
So if there is no doubt, we can wind up. You can ask your doubts in the coming sessions also. Okay.
You can ask your doubts in the WhatsApp group or message me personally in WhatsApp. So I can forward it to ma'am and I will clear your doubts. So thank you all for participating in the session. Thank you, ma'am, for this wonderful presentation. Thank you for your time, insights, and engagement throughout this session. And thank you all participants for your interactive participation. So we will see you in the next session on Friday, 3 p.m. Thank you all.
Thank you all. Okay.
Have a good day.